Cool. All right. All right, group. I Am Legend. Where would you like to start? There's no wrong answers.
Well, I love this movie. I like Will Smith way back then, first off, but the characters, um, a, in my mind, a good person who is really struggling with some serious PTSD in this movie. He has continuous flashbacks of his family dying, of the events leading up to his current situation. And he copes by the relationship that he has with his dog, and it's a very real and sweet relationship that he has. But you see you see his desperation to cope and to socialize with the mannequins that are set up around the town. Um,
Well,
and
let's actually pause there. What is how'd you feel when he went in that video store the first time versus the second time? I mean, take me through that. I want to know what you guys were experiencing.
Really sad. I think initially he kind of had like this hope of like human connection. He was more hopeful, but when he went back the second time, he knew that the mannequins weren't real and that they weren't going to actually like answer. So that was like kind of showing that he lost hope that he was ever going to find anybody else.
First time you're observing this as a psychiatrist, or let's say that Robert Neville presents to you for psychiatric care. And the information provided during the initial assessment is taken from that first visit to that video store. What's going through your mind? Are you ready to hospitalize him? I mean, we're not in a future dystopia. This is Robert Wood. You have full resources. You're going to sign him out to and discuss him with your next level supervisor. You're attending. What are some of your thoughts?
there's a serious connection and delusion there. Not that when you're hospitalized for delusion that you're able to change it, but
No, we're going to give the inpatient docs the benefit of that. Anybody agree, disagree?
I mean, I'm thinking like he's not really like a threat to himself. Like, yes, he's delusional, but he's not suicidal as far as we can tell. You'd say maybe, I mean, he's killing a lot of the others. I don't know if you'd say he's a threat to others. It was kind of his whole job.
Mhm.
But I think able to care for himself. He's like functioning, but he just have like delusions. So I would be more on the fence.
And when you say he's experiencing delusions or is otherwise demonstrating a breach in reality testing, are you focusing your clinical attention on his interaction with the mannequins in that first encounter? How do you interpret that interaction? All right, so if you're going to pause and you're not sure, what have I asked you to adopt in terms of a frame of reference? Just last week or the week prior?
That it's normal behavior.
Right.
Yeah.
And what evidence would suggest that this is normal behavior?
He demonstrates later some insight that like he knows they actually will come back.
Right, doesn't he?
yes.
Right. And then taking and let's say that we were about to go. Actually, let's say keeping you in your scenario. Let's say your attending has the thought of it sounds like he needs to be hospitalized. Sounds like he is psychotic. Feedback from the medical student to a CL doc is, well, Dr. So-and-so, you do the same thing. What's the medical student referring to?
Like when you're isolated.
And this is in the context of a broader behavior. So what is the medical student referring to? Mannequins plus other stuff. Because you're telling me he sets up the mannequins in such a way, right?
like talking to yourself kind of thing.
More than that.
Like desire for human connection.
Yeah, and consistent human connection, right? I mean, his idea might be that if he doesn't position the mannequins where they are, if he doesn't go to the video store exactly at 11 o'clock every morning, whenever he does, if he doesn't drive golf balls at that particular time, whether it's twice a week, whether it's daily, the way he does, whether he doesn't see D, E, F, or G, and he puts in, VCR tapes very consistently. What is it? What is he doing? It goes a little bit beyond human contact.
Like
Filling your
rituals.
response.
Obsessive.
Why?
Right, like so he just doesn't get distracted and think about everything that's really going on. Like,
Part of it. Is there another reason why he's doing it?
Maintain a sense of normalcy in his life.
Go with that. Give me more.
I
What do you
think
mean with normalcy?
he's almost like ignoring what's happening. Playing golf, he wants to like ignore the wasteland that's around him, like not acknowledging that one, there's a safety risk. Two, there's like no need for him to go to the video store every day. That's weird.
Right. Why is that guy? Why is he doing it? Well, and here's another I think aspect of this, another example of this. Why would a guy who was literally the last man on earth, and I'm pulling that from the previous title of this movie, not to suggest that who he does find and who he does meet is a product of his imagination or mind, not to actually go down that path. Why is a person like that in his situation setting an alarm clock? The heck? Or not live streaming, right? Right. That actually was the reason when my daughter didn't last 7 minutes into this movie. She saw that and said, "I'm done, Dad. This is ridiculous. I'm never setting an alarm clock if I'm the last person on earth. Bye." Right. Got up and walked out of the room.
I think so he still has a lot of motivation and an end goal.
Why can't you have motivation and goal waking up at 11 o'clock every day?
I think he like needs a sense of discipline
Why?
because that's how his former life was, and I think he's probably trying to hold on to some sense of normalcy and control. Yeah.
Normalcy, control. You guys are circling the drain. You're just not saying it.
Borderlines with people. So it's the same thing, exactly the same times. They sort of become almost compulsions for him. He feels like he needs to do them.
And all this, or a lot of this could have been pre-existing. No doubt about it. And he is a doctor. If he doesn't set the mannequins up the way he does, if he doesn't go to the video store the time of day that he does, as frequently as he does, if he doesn't set the alarm clock, doesn't do any of this, what might be something that happens as a direct consequence? He'll get psychotic. Why? Where have you seen this before? CL. Delirium. Right? Now, we often are not at the epicenter of this because it's only after nursing and others employ, quote unquote, the delirium protocol that the patient remains agitated that we get called. But wake up the same morning every day, food comes the same time of day, family, reorientation, lights go on when the sun is up, lights go off when the sun is down. We try to really maintain all of those external cues to make sure that our day-night diurnal variation stays consistent. Because if it doesn't, you will become delirious. Right? That's what he's protecting against. The reason why he is so regimented. That's why he does things that if you're the last person on earth, you wouldn't ordinarily do. He understands that. Right? And this happened in COVID. I mean, well, during the time when we were at our peak, I was actually asked to do an interview about how we can protect ourselves from depression, et cetera. Not necessarily delirium, as this pandemic began to evolve. And one of the things I said is, given the quarantines, what's going to happen is that we're going to lose a lot of the external cues that make us do and function the way we ordinarily do stuff and function. So we have to now make a conscious effort to keep those intact because they're not going to come as an automatic anymore. That's what we have to pay close attention to. We're going to be working from home. We're not going to be going out. We're not going to be doing those things that are going to be putting ourselves in those situations where those external cues will be consistent because we take them for granted. They're going to be gone. So we need to think through and be an active partner in creating those external cues for ourselves. And if not, we can become depressed, we can become anxious. And in the worst case scenario, we too can become psychotic. We can get delirious from that. So he understood that.
So it kind of makes sense that when that mannequin was where it wasn't, he kind of flips out and shoots everything. He shoots the mannequin, he shoots all the way around him because he realizes that maybe I might be becoming delirious because the mannequin's not where it's supposed to be.
Let's talk about the differential. Yeah, that is, Fred is the turning point in this movie, right? Because there's only about 2, maybe 3 scenarios that are possible when he sees Fred outside, right? What are those scenarios? And you just mentioned one where he realizes he's losing his grip on reality and it's over. I mean, remember what he says, I believe, into the mic or the tape recorder prior to, right? And I'm going to paraphrase. They outnumber me, maybe 1,000,000 to 1, maybe even more. However, I have executive functioning, right? That's my advantage until all heck breaks loose, right? So another part of the differential is that no, I mean, this is proof that they have executive functioning, right? And all of a sudden, he understands that he's dead. Within hours, he's going to die, right? And hence he acts out the way he does. But then the third scenario might be even worse, and that is we have evolved from a zombie film to a supernatural horror film, and Fred can move by himself. Then you not only have now the zombies to worry about, but evil spirits, and that's game over too, as far as I'm concerned. Right. So, I mean, is there another scenario that? I mean, what else can it possibly be? I moved it, and I don't remember. It's called dissociative amnesia, and I'm in trouble because I'm losing my edge, and I'm incredibly outnumbered. I'm incredibly outnumbered, but while I maintain my edge, they have an edge that I didn't see coming because I always thought that they were less intelligent, rudimentary functioning, and they're not, because now they're manipulating me, and that's a trap. And he denies that and walks right into that trap, quite literally. Then, of course, that third scenario, which is we're dealing with a supernatural horror film all along, and game over. His reaction to Fred's moving, and his reaction to Fred having moved is the turning point in this movie. Other observations about Robert Neville. Remember, we talk about human behavior in the context of what predisposes, precipitates, and then perpetuates human behavior. What maybe predisposed him moving towards Fred and being snared in that trap? But this idea that he's maintaining this denial that they may actually have executive functioning. Now, that can be preserving because I think if you realize that and recognize that day one, you can become incredibly dysphoric about what your imminent future is. So there's a part of adaptability of that defense mechanism of denial. That said, there may have been something that predisposed him to also adopt denial as a defense mechanism. So what are some predisposers that we, through flashback, we believe may have been in place here? And this question really is directed towards those that are zombie fans. Generally speaking, somebody doesn't want to admit that a zombie or other is as intelligent, perhaps more intelligent than you are. What's your differential diagnosis?
I mean, it could just be sort of a grief reaction because if they are as intelligent as him, he's been murdering them, which is sort of hard to cope with.
Yeah, it could be. Yeah, I mean, when another defense mechanism, one of the reasons why he rationalizes what he's doing, I am legend, I'm saving the human race, might actually fall apart. That foundation is crippled if you realize these are not just these mindless beings; they're actually free thinkers. That's a good point. The other reason why a person would not be able to tolerate an idea or the idea that someone, another, is as intelligent, perhaps even more intelligent than they are.
Narcissism.
Yeah. Yeah. And the evidence in this film that Dr. Robert Neville may have narcissistic personality traits.
Like when he meets the woman and her son, like the whole time he's been thinking like, I'm the only human alive, I'm the only hope for humanity. And she comes in and says, well, no, there's this whole other colony of people who are alive. So it's like, it's almost like, what have I been doing this whole time? Like trying to save humanity. Meanwhile, there's a whole other group of people who are alive and surviving without me and my intelligence and all this stuff.
Yeah, that would stink.
Yeah.
All that I'm doing, and a woman and a kid are just as survivalistic as I am. That with everything he's got going on, he got a lab, right? So here's the counterpoint to that, and I do agree with you. The issue, though, for me would be, all right, well, we see that in that slice of time. Might this be a pre-existing condition? So this may not have been necessarily brought about by the zombie apocalypse itself, if there's any evidence that it was in place prior to.
The narcissism?
Yeah.
I think so. Like when his wife and daughter were trying to get past the checkpoint and she's testing, like she failed the test and he's like, oh, I'm the colonel, I'm ordering you to test it again. But like other people never got tested again, but now just because you say so and you pull out all these like big cards, now I have to test her again.
Yeah.
So I think it was evident already.
And we need a prequel to this.
Mhm.
We do need a prequel, but I have a sense that you're actually correct, and that Robert Neville probably had some evidence of narcissism prior to the zombie apocalypse. And I mean, the guy did cure cancer, right? So remember, this is Dr. Frankenstein. This is someone who has that sense of narcissism, and the way he cures cancer is concerning because we see a byproduct of it in that it disrupts the immune system and creates these other beings, which, don't know if he had evidence of that and pushed through anyway. He didn't have evidence of it and came back as a surprise to all that were involved. Who knows? That's why the prequel would actually be very interesting.
I think even more so, like he was like his family wanted him to like go with him, but he's like, no, this is ground zero. I have to stay.
Hmm.
So like you rather like be separated from your family than like admit like maybe this is something beyond your control.
Yeah, your family's your legacy.
Yeah.
Yet for him, it wasn't.
Right.
There's something in his mind much larger. So there is evidence that something was pre-existing, and that would be consistent with a personality disorder in as much as we understand personalities to largely be crystallized late adolescence, early adulthood, and then stable across the life cycle. Definitely an area of further inquiry. Other aspects of Robert Neville you want to discuss?
He does try to kind of commit suicide after his reality's shaken.
Why? What's the again, remember, predispose, precipitate, perpetuate. There's no perpetuating factors post suicide. So predispose and precipitate. What's the precipitant?
The loss of his dog.
And then what's the predisposing element or factors?
Losing his family.
Yeah, his dog's the only remaining part of his family. Remember, it's the puppy that his own daughter gives him. The dog is his daughter. Yeah, and he has to give everyone up. He has to give his wife and his daughter up when his dog dies, when he has to kill his dog, which makes me believe, in terms of the way that was done, that scene was very difficult to watch with him crying, with the dog having to break her neck because of her turn. He believes that he killed his wife and his daughter. I see a parallel there. Right, he's the one that pulled rank and got them on that copter, right? So, and then as a result, he's severely depressed and attempts suicide. Other observations, Dr. Robert Neville.
I feel like even like his suicide was like kind of like a last show of narcissism because like he gives her his vial of blood. So like even after he dies, they'll know like he was the one who saved them.
Yep. Yeah. Oh, yeah. Mm-hmm. Again, he's decided what his legacy is going to be.
Right.
Mm-hmm. If he were to present to you, and we're thinking that there's a major depressive disorder that is co-occurring with elements of post-traumatic stress, given his nightmares and flashbacks. What different signs and symptoms would you like to review now to see if he rolls in for major depression?
Just going down the city caps.
Right, and for the the undergraduate interns who are following on the other side, you want to just name SIGI caps?
So there's sleeplessness, I forget what I is it irritability? But it's basically a screening for depression, so you sort of go down and you need a couple of them. So sleep, interests, guilt, energy, concentration, appetite, psychomotor, and then suicidal ideation or attempt.
Good. A total of 5 over a 2-week period that hallmarks a change from previous functioning. If you meet the criteria for more than 2 weeks, but it is not a change from previous functioning, what might be part of your differential diagnosis then?
PDD?
Yeah, persisting depressive disorder, otherwise known as, or previously known as the thymic disorder, persisting depressive disorder. On a shelf exam, you only actually need 2 of SIGI caps. And for all intents and purposes, it is the same criteria. Not that I don't think it'll come up on an exam, but psychomotor agitation and suicidal ideation are not part of PDD's definition. And instead, poor self-esteem is. Self-esteem. Not to say individuals struggling with depression have wonderful self-esteem. It's just a little bit of a tweak when you're looking at the other definition. That definition of post-traumatic PDD or persisting depressive disorder follows the rule of 2s. So 2 criteria, not 5, over 2 years, right? And never more than 2 weeks without symptoms. 2 weeks or 2 months? 2 months, right? 2 months without symptoms. Right, so the rule of 2s.
If you're asking, what would it be if it's less than 2 years, but not a change?
Chronic depression. I mean, it's the best I could come up. I mean, assuming that you've investigated and ruled out other confounding factors like co-occurring substance use, assuming everything else was a clean slate, I would think chronic depression. Right. The textbook depression, untreated, figure 6+ months, treated half the time. There is a subset of that, a percentage of that, that will recur. And then there's a subset of that in which the inter-episode recovery will not be full. And I think that's what we're talking about there, if that makes sense. Right. So again, individuals with depression have a time for textbooks, 3 to 6 months, 3 versus 6 months, whether or not it's treated or not. In cases where they're not treated and you're thinking about 6 months, there's a percentage of that actually will go on with recurrence. And then there's a percentage of that in which the inter-episode recoveries will not be full. That's exactly where I think we'd be then, or at least the first thing I would think of to investigate. So Dr. Neville comes with a chief complaint of movie script here, and you diagnose major depressive disorder with co-occurring post-traumatic stress disorder. Biopsychosocially, how would you like to address his management?
That can't realistically be addressed, like, without the context of the movie, because his PTSD is due to things that happen in the movie. But theoretically, like a lot of CBT.
Yeah. Right. So psychotherapy referral, CBT is probably going to be at the very top of that list. Efficacy for both the anxiety disorders as well as the depressive disorders. As he's undergoing CBT, you don't actually feel that he's making significant improvement, or he's demonstrating significant improvement. And upon reevaluation, what else might you recommend at that time? Yeah, I mean, pharmacotherapy, antidepressants in general, and then, of course, antidepressants that would also have a secondary indication per the Food and Drug Administration in treating post-traumatic stress. And there, your highest yield class of antidepressants would be the SSRIs. The other thing, not necessarily, and this would probably come outside of CBT, but grief therapy too. I don't think CBT is going to cover grief therapy or bereavement therapy. If we're looking at an evolution, if we're going to refocus from PTSD just for a second and look at the depressive disorder and look at its etiology and its progression. Neville presents to you with the same exact signs and symptoms, and that will not include suicidal ideation or attempt. One day after seeing a helicopter blow up, right? Focusing on the mood and SIGI caps. What is your most likely diagnosis here? And what mood disorder will you diagnose him with about 24 to 48 hours after that accident? Depressive symptoms. Close. Yeah. So normal grief, aka bereavement. If you're ever asked, bereavement's the syndrome, grief is the feeling. But in clinical practice, we interchange those terms all the time. So grief, bereavement. If that course is protracted, and or if there is qualitative evidence to concern the clinician, suicidal thoughts, what might be the single best answer at this point?
Less than 2 weeks though.
Yeah. It's a type of adjustment.
With depressed.
I would give you that, but if you're playing the single best answer game, consider persisting complex bereavement disorder, right, which the APA created back in 2013 to bridge normal bereavement or just bereavement, which is always normal, to major depression. Now, beyond 2 weeks, fulfilling full criteria, again, 5 out of the list, you're dealing with major depressive disorder. Right? So again, if we saw the prequel, or not the prequel, because we actually see him in the beginning of this movie, but if we actually had a day-by-day account, we might actually see that progression from bereavement, which is defined as normal, i.e. is not clinically significant, to persisting complex bereavement disorder, which by definition is clinically significant, but does not reach full criteria or meet full criteria of major depression, to that third step or the third stage of major depressive disorder. Questions about the continuum of the depressive disorders? What other depressive disorders are to be considered, not for Dr. Robert Neville, but in general practice when undergoing this evaluation and providing this evaluation? Depressive disorders. Probably
Sure, he doesn't have bipolar.
That's true. It'll be in the differential most definitely. But we'll leave the bipolar and related disorders chapter out of this for now. Probably 4 more. Also bipolar and related disorder.
Resistant depression.
Definitely a real thing, not necessarily a diagnosis. It would still be major depressive disorder. That's a subtype. We can get into those too. So that's a subtype of depression. Well, there's 4 more. 2 are so easy, and you've discussed them so much that you're just ignoring them now. You would automatically think, well, Tobia knows those. He's not asking about those. What are they? Person comes in with depressed mood and rolls in for SIGI caps. You can't diagnose SIGI caps until you evaluate for what? Substance-induced depressive disorder and depressive disorder due to a general medical condition. Right, so those are the 2, or intuitive. So I'm going to give you guys that. There's still 2 more. One's diagnosed in children. And the reason why we created this diagnosis, the APA created this diagnosis back in 2013, was to reduce the number or the incidence of diagnosing bipolar in children. Disruptive mood dysregulation disorder is a depressive disorder. Right? Disruptive mood dysregulation disorder. And there's one more. And the hint is not necessarily focusing on Dr. Robert Neville, but in general practice. Another qualifier, that's an onset qualifier of major depressive disorder. Premenstrual dysphoric disorder. And if you get this on a shelf exam, they will always ask you in terms of onset and offset of symptoms and what it directly links to. So what does it directly link to? More specific. No, it is PMS. It's the new clinical term. Progesterone. Progesterone is the culprit. So you have onset of symptoms about 1 week prior to one's menses when progesterone is at its highest peak, and then you have symptom resolution the week after, which is when the trough of progesterone is. And that's why it's really not a mental disorder. It's a depressive disorder due to an underlying condition, specifically the menstrual cycle and progesterone. So at some point, I think the DSM or the APA is going to remove it from the chapter and create a other medical conditions chapter. Further thoughts or final thoughts on Robert Neville? What are the characters you want to focus on, discuss?
Well, it's not in the movie, but I would wonder how, if the helicopter didn't explode, like how his daughter would have like grown up, like what, if any, I'm sure there would be like disorders she may have developed, definitely like PTSD, and like how those ACEs would play into like her development.
Mm-hmm. Mm-hmm. Yeah, I think it would be very interesting. Given the event that we observe, of course, connecting the dots in terms of talking about a 35-year-old woman. What else happened in the interim? Did she see her father again?
Like, was it ever like confirmed that they're dead?
No.
So that's always what I thought. Like they could still be alive. Right? Maybe they made it to all years.
That's the sequel.
Well, I want to also think about that, the one that was smart, the one that, at first I had forgotten the movie because I've seen it once before, but I thought that there was some real emotion there. It seemed like in terms of Neville getting the female dark walker, is that what
We'll call them a zombie.
the zombie, yeah. I thought there was a personal relationship between the one who was out to get him
Oh, yeah.
versus the woman, and right.
Mhm.
So I thought that was interesting, and psychiatrically, I don't know how that connects. It's just that there was an attachment between, you know, I thought between him and the female zombie that was caught, and so there was a higher cognitive functioning going on that, of course, Neville had no
Missed.
idea about.
Yep. Yeah, I think that observation is twofold. One is through the perspective of Robert Neville, and then more of a third person understanding of what that means. I think we discussed Neville's perspective already. It's certainly filtered through with a degree of narcissism, if not narcissistic personality disorder. But taking the other perspective, which would be the third person perspective, and looking at this, I think there's something further to gain here. So trying to figure how best to kind of begin this discussion. Um, Dark Walker or zombie. We were talking about this earlier in a smaller group, but the evolution of the zombie, especially the U.S. zombie, really took a significant turn back in 1952. Right? Previous to the early 50s, zombie were considered undead and were largely the product of voodoo. Right, so the zombies started in Martinique and then spread with the voodoo religion in the Caribbean. In 1952, that changes. It changes with the novel penned by Richard Matheson titled I Am Legend, right? This is an adaptation. There was an initial adaptation called The Last Man on Earth, and that was starring Vincent Price, old-time actor. That was in the early 1960s. And then a remake, which everybody here watched. In 1952, the cause of the zombie is not voodoo. In 1952, in the original novel, it's the narcissism of the medical. Right? There is a virus in a bat, and things just escalate from there. Right? So it's an infective cause. Now, how does the infection result in either the slow walker, that's the Romerian zombie of 1968, the Night of the Living Dead, and then other fast walkers or similar to the ones that you watched in the Will Smith remake. How does the infection mediate the creation of the zombie? Well, the intermediate step is going to be the immune system. This is why he's trying to cure cancer, the immune system. Right? It's called cytochrome storm, and not cytokine storm. Cytochrome storm is something else. Cytokine storm. This is the immune response not turning off correctly. Right? So the immune response cascades when there's an infective agent, and for hopefully all of us, when that infective agent is neutralized, our immune system shuts off. Okay? When it doesn't, we have persisting systemic inflammation and inflammatory response that could become even worse than the initial infection. That's exactly what happens to these patients. And that's exactly why we see the zombie be created, and especially since 1952. Some of the aspects of these zombies that result from the dysregulation of the immune system include, stop me if you disagree, irritability, right? Definitely a change in sleep cycles. We have them being up at night and hiding during the day. Certainly psychomotor agitation, that's the Will Smith I Am Legend zombie, versus psychomotor retardation, and that would be more of the Romerian zombie from The Night of the Living Dead. There's certainly a change in appetite, and that comes with Romero too, with them eating brains. So we do see some aspects of this infection result in a change in the way that these creatures behave. If such a zombie presented to you in clinical practice and you chose a career in psychiatry, what diagnosis do you think they would actually leave with? And by the way, Neville himself talks about the very base understanding they have when it comes to cognitive processing. So deficits in memory, concentration, attention as well. Single best diagnosis for somebody presents to you with irritability, cognitive decline, or difficulty concentrating, change in appetite, change in sleep pattern.
Depression.
Yeah.
Drug-induced depression psychosis.
Yeah, it starts with depression, right? And as part of working the individual up for depression, certainly rule out the effects of a substance or an underlying medical condition. But major depressive disorder fits real well here. And the real interesting part of this is that, similar to our discussion of the evolution of the zombie post 1952, recent literature, medical literature, the emerging evidence is that the immune system plays a significant role in the progression of depression. Right? Our body's immune response does not shut off correctly when we're dealing with states of chronic depression, especially. So Matheson maybe not been in on something here, or been certainly a little bit ahead of its time. And the immune system does play a vital role, not only in the creation of the zombie, but the progression of depression as well. Right? Immunopsychiatry is significantly rapidly growing branch of psychiatry. So the general idea to take this to the next level when it comes to, we talked about treatment already. Now let's take what we just discussed and reapply it for our final thoughts back to how we can help our patients, or how we can help Dr. Neville if he were presenting to us. And the other thing too, I'll mention as well, you have a patient, Dr. Robert Neville, who we can discuss with regard to presenting as if he has major depressive disorder, largely due to a zombie apocalypse, the zombie itself being a metaphor for the etiology of depression, at least the biological etiology when it comes to the biopsychosocial factors that contribute. All of that said, if trying to think, if you look at the way in which serotonin is synthesized, what is the precursor? What is the initial substrate? Even before that. Yeah, tryptophan, right? From tryptophan, we get serotonin. From tryptophan, we also get quinolinic acid, which is a neurotoxin, right? What pushes the equation to the right and allows us, actually, I shouldn't say that. If we push the equation to the right, we're going to get the synthesis of serotonin. What instead would push the equation to the left, away from serotonin, and instead creating the neurotoxin? So there's an enzyme, I think it's either ITO or IDO. I don't know if it's di or tri after that, but it's IDO or ITO. There is something that enhances the expression of IDO/ITO, pushing that equation to the left, and therefore resulting in less serotonin and more quinolinic acid, and it's actually infection, right? I want to say it's IL-6. So in treating depression, we focus only on the right side of that equation and increase the CNS serotonin and dismiss anything we might be able to do to lower the inflammatory state, to neutralize the actual effect of quinolinic acid. Questions?
So if it did go to the other side, is there anything that would show up in like labs or like?
No, so non-specific. So you think of CRP, other non-specific markers of systemic inflammation. That is it. And even then, what would you do? Give them an aspirin a day? I mean, I'm not sure what you'd actually do. Now, I absolutely know some psychiatrists, given the emerging literature, that upon initial evaluation for depression, and I'm not actually advocating for this. Matter of fact, I advocate against this until more research is done. They give a script of a Z-Pak. Yep, here's your Prozac and a Z-Pak, because of what the initial evidence looks like here. Again, I think that's way too early to actually do stuff like that. And I really don't know the clinical utility of getting a CRP. I guess you get a set rate. I mean, even the platelet count as a non-specific acute phase reactant. Questions? Have you ever seen an animal model where an infection causes pre-programmed behavior? Rabies? Anybody here ever hear the zombie ant? All right, so it's the liver fluke infection. And I'll post the link on Twitter. I'll get that to the Twitter group. It's a short video. It's creating a cartoon. It's very easy. Even I can understand it. But the life cycle of the liver fluke requires the ant being a vector and the ant needing to be eaten by usually a cow. It could be other ungulates, but it's usually a cow, so that it can complete its larva stage in the liver of the animal. And the only way to get the ant eaten is to take over its central nervous system and have it march up a blade of grass every night at dusk, latch on with its mandibles until it's eaten. And if it's not eaten, it goes back to its colony. And the next day at sundown, it goes right back up to that blade of grass until it's eaten. So pre-programmed behavior to complete its life cycle. The larva could hatch in the liver of the cow. Right, the zombie ant. So I'll look for that video and I'll post it on Twitter later. We also know there's a human model to this too, where individuals diagnosed with having schizophrenia and with co-occurring cryptococcal infection have risk for committing suicide, a completed suicide, when compared to controls having schizophrenia alone. So again, some element of pre-programmed or infection resulting in suicidality. So it goes beyond the zombie ant. So something about cytokine storm, the immune system mediating a change in behavior. And that is why you watched I Am Legend. Other than it being an awesome movie, or an awesome novel. Questions? So the ending that I watched had him. Yes, yeah. I prefer the other one though.
Really?
Yeah. So I thought that the other one would have been more consistent with the original movie starring Vincent Price, because there's a nice twist at the end of that movie where Vincent Price's character, which is, I don't know if he goes by the last name of Neville, but it is Robert Neville, believes he is Legend because he's going to be the one to actually defend humankind against these, as he called it, a scourge. And he meets this woman, Ruth, and she's kind of suspicious of him and he's suspicious of her, although she's clearly human, only to be revealed later, spoilers, that she actually has the infection. It's just that she doesn't manifest the symptoms. But her people are outnumbering him and he should just give up. She actually reveals his hideout. The zombies are surrounding him. In his last breaths, he realizes that I am Legend, not because I'm going to save humankind, but because this whole time I've been the monster. The new world order is of zombies and humans are the monsters. And I'm an urban legend to them. I'm that sickened creature, the hideous creature that frightens their kids at night. And that's the revelation that he has in his dying breath. I just thought the other ending was more consistent with that. Kind of related. Anybody here do the Asbury Park zombie walk? No. So I got, I think a few medical students have reached out to our program director with some interest in participating this upcoming October. We go every year, and on occasion we've actually had depression screening tents. If you look at the literature, when there's depression screening outside of a physician's office, the rate of screening positive is up to 20%. For us, it was like 84%. So we thought zombie walks might actually be a very niche venue to screen for major depressive disorder. So if anybody's interested, let me know. We actually did some fun stuff. At our tent, I won't get into the details here, but I'd be more than happy to discuss everything we did if you're interested. But I think we're gonna not only go, well, we go every year, but I think we'll have another depression screening this October, largely because there's some medical students that are really interested in providing that, and have already contacted our program director. All right, we'll leave it there, guys. Blue team, we know of anything new coming up?